Welcome to this Beyond Zero e-learning module on an approach for clinicians on patients on ARVs not adhering to treatment. This is module 1 of 3 modules and will look at the personal factors that contribute to better adherence in patients and how we can strengthen those qualities as a clinician. With the massive advances made in the treatment of HIV, no patient need develop AIDS or be made sick by HIV infection. And yet every day clinicians still see patients with deteriorating HIV disease. The vast majority of these cases are due to poor adherence to treatment, and nurses and doctors despair at their patients not taking their tablets. Much has been written and researched on external factors that affect the ability and motivation of patients to take treatment regularly. We are aware of the influence of socioeconomic factors, poverty, stigma, lack of disclosure, substance abuse, etc. But the question needs to be asked why some patients who live in the same difficult circumstances manage so exceptionally well. Why do some people seem more able than others to take their treatment? In this tutorial, we will look at 3 levels of capacity that contribute to an individual's ability to take treatment and how we as clinicians can strengthen these capacities. It will include health beliefs or mental capacity, emotional intelligence, and self-efficacy. The first type of capacity, and the most familiar, is the mental level, the level of ideas and thoughts. Please note that I do not mean intelligence. Someone with a lower intellectual intelligence or level of education may need a bit more time to understand the treatment plan and the illness, but one does not need a high IQ to grasp the concepts important to HIV. We know that treatment literacy contributes hugely to the ability to be adherent, and most of our adherence counseling is based on teaching our patients HIV concepts and is an important part of the counseling approach. But what is given less attention is the health beliefs that the patient already holds. No patient is a blank slate. He or she comes to the clinic with presets, ideas and beliefs about HIV, AIDS, ARVs, etc. Schneider et al. Specifically mentioned that the understanding of a patient's health beliefs is an essential part of strengthening the doctor-patient relationship and improving adherence. The more our patient's health beliefs are concordant with your beliefs as a healthcare worker, the more likely the patient will be able to follow the instructions. The key message here is simple. Listen before you tell. First, elicit what your patient knows through patient inquiry, not interrogation. You want to ensure that clinician and patient have the same health construct regarding the patient's treatment plan. Module 4 outlines some interesting ideas around understanding both your own health beliefs and those of your patient. But as we all know, simply having knowledge about your treatment does not ensure the ability to stick to a treatment regimen long term. This brings us to another type of capacity that has been receiving much attention over the past couple of decades. Emotional intelligence, or EQ, describes our ability to recognize our feelings, identify the needs that underpin them, and our ability to manage them to our advantage. In addition, a higher level of EQ will give us the ability to identify the feelings and needs of those around us and interact with other people's emotions more appropriately. The more one believes that one's feelings are created by a locus outside of oneself, for example, by events outside of one's control or the actions of others, the more vulnerable you are to the issues of stigma and victimization. People with a higher emotional intelligence is more able to cope in an environment of stigma and negativity around HIV and not internalize the negative messages in the community. They have a thicker skin and can distance themselves from the opinions of others and do what they believe is best or right for their own health. EQ is different than IQ in that it is possible to strengthen someone's ability to recognize their needs that underlie their feelings. Our adolescents are particularly vulnerable. At around the age of 13-14, a young person develops an independent, powerful feeling life, but are still unable to understand their own needs and more likely to project their feelings onto their environment. Adults who are able to help adolescents understand their own feelings and needs can be powerful allies in helping them build resilience. The third type of capacity is that of self-efficacy. Self-efficacy refers to the ability to act, the ability to implement those plans and big ideas we have for our lives. A person may have a lot of knowledge, may understand their needs and feelings, and yet do not have the power to follow their dreams. A high level of self-efficacy is directly linked to the ability to be adherent to treatment. A person with a good level of self-efficacy will manage their treatment regularly, and our clinics are filled with people from difficult circumstances who attend their clinic dates, stay healthy, and whose viral load stays suppressed for years. Self-efficacy is a skill we would like to expect of all adults, but it is dependent on a child being educated by parents and teachers in a way that builds their will and independence. But what can we do as a clinician? If a patient has a high level of self-efficacy, it would not be possible for a clinician to have a negative effect on his or her adherence. But in vulnerable populations, and especially with adolescents and youth, it is possible to worsen your patient's ability to take charge of their treatment plan. This is not about a single visit or the odd encounter at the clinic, but the hospital clinic culture that the patient is exposed to. So how exactly do we make things worse? A vulnerable patient whose views are not taken into account, who is preached to and lectured, who experiences disapproval and tongue-clicking, and who is treated like a child, is less likely to take responsibility for their treatment and their health. This is especially true of adolescents and youth, but also with patients with low literacy and poor confidence. The clinic culture may reinforce the idea that they are powerless, and this in itself becomes a self-fulfilling prophecy. On the other hand, how do we strengthen a patient's self-efficacy, and how do we help them to become more responsible and accountable? By treating our patients with respect and warmth, by listening to their views, by accommodating them when possible, and by treating them as responsible adults. These simple approaches can strengthen your patient's self-efficacy and their ability to help plan their treatment and engage in treatment. One can see how this becomes even more important with those patients who seem to be irresponsible, apathetic, or uncooperative. In summary, over and above the need for patients to have knowledge of their treatment, their health beliefs also need to be understood. We need to help them identify their feelings and the underlying needs, and strengthen their self-capacity by treating them with the same respect and care we would expect when we were visiting a health professional. The important take-home message is that it's not only what we tell our patients, but how we do it that can either strengthen or weaken their ability to engage in treatment. This becomes even more important with our so-called non-adherent patients, when the temptation to lecture and disapprove is so much higher. When you have a patient who is failing on treatment, first look at yourself and the healthcare environment you are fostering. For a framework on how to discuss adherence issues with your patient, see Module 2. Thank you for joining this Beyond Zero e-learning module. Please see the notes section for more information on other modules and downloadable resources.